Thank you very much, dear Chairman, ladies and gentlemen, dear colleagues. I like to talk about possible ways how to integrate 3D imaging and printing in RVOT management. These are my disclosures. 3D imaging means to use already available imaging data and present them plastically in a natural way, in a way how we use to capture things in normal life. So everyone can decode this information and the whole team is on the same state of knowledge after this. RVOT management starts early in life with the initial repair and surgery. The focus on 3D imaging at this time is to present all the malformed anatomy in a comprehensive way. Later on, the focus is how to optimize the blood flow to the lungs. The 3D information comes from different modalities. MRI, for example, is mostly used in older patients, whereas the new technique of CT with its high resolution and now with its lower X-ray provides perfect results in younger children and babies. 3D echo is often hindered by its small acoustic window and it's a bad acoustic window and small angle of view, and it's very difficult to extract the 3D information from the echo machines to use it in other 3D programs. 3DRA is acquired, the rotational angiography is acquired intraprocedurally, and it's very invasive and with a bad temporal resolution. But for example, in pulmonary valve replacement, in percutaneous pulmonary valve replacement, it seems to have one of the last eligibility in congenital heart disease. 3D for the initial repair means that we need a very high resolution data set, for example, from CT to optimize the clinical course for these patients. The best information is needed for an optimized decision making. The surgical planning at this time is evident and very important. So if we have a possibility to inform the whole team in a perfect way, we should use it. The presentation of cross-sectional images like here on the left side will be not enough to inform the complete team, because the 3D understanding is very different in the persons, in the whole team. And if we can use a 3D model, the complete team will be on the same state of knowledge after looking at this, like in this patient with a double outlet right ventricle and the aortic malformation here. The working horse of 3D imaging is the volume rendering technique. This appears with only one clicks, several clicks in the machines, in the 3D machines. We can see these patients with a pulmonary atresia and VSD. That's the original data set is a CT, and for example, we can visualize the central pulmonary artery in nearly every patient. On the right side in this slide, you can see a new form of volume rendering technique that's the cinematic rendering, which was introduced several months ago. That's the same lighting settings, but which, with a better natural depth in this data set. The information is more photorealistic and with a better shape perception. The segmented and triangulated tessellated hard models, the STL models, are fine delineated, colorful, and easy to understand. It's the same patient. They are very accurate, and additionally, they are independent from the huge original data set. So we can send this data, for example, for communication by a PDF, and this can be read with any PDF reader. We can rotate this model and cut inside with a normal free Acrobat reader, for example. And in difficult anatomy, we can show segments and we can hide segments to have a nice view on the pathologic anatomy to plan the surgery in a perfect way. These STL models are threshold-based and very accurate. In comparison with the gold standard measurements, MPR, they are more accurate than the RVOT models, and with a deviation of only 0.5 millimeters in CT, for example, they can be considered as nearly perfect. So rotational angiography is acquired intraprocedurally while ballooning the pulmonary artery. This helps us to see if the potential stented valve produces compression of coronaries or the aortic root. Here we can see, for example, a compression of a coronary artery by the balloon. In this case, it was not a coronary compression which leads to the abortion of the procedure. As you may see here, there is a stenosis of the left descending coronary artery, better seen here in the selective angio. This wasn't seen in the CT, which was performed 2 months ago to rule out a coronary disease. That's one reason why we don't use rotational angiography in most cases in congenital heart disease. We can use already available imaging data, for example, here from CT, to segment this image information, produce an STL model, and we can overlay this on both planes of the angio without any contrast. At last, I like to propose another method of 3D printing to use it for education in the cath lab, for example. That's a patient with a wide outflow tract. The base of the imaging is an MRI. We can segment this heart and print it, thanks to Materialize for printing me several heart models for this research. And then we can use high flexible silicon rubber, like it is used in mold making for small industry series, for example. And we can produce a block of silicon where the heart was, the printed heart was inside. And we can use it in the cath lab for education. We can open it. I produce them in 2 layers. You can see the melody valve here, for example, inside this box of silicon. And then under radiation, there seems to be a very realistic model. Here, for example, That's the semi-stiff wire, the 6 French guiding catheter to put a stiff wire in here in the left descending artery. We have a nice contrast between silicon and air, so we don't need any contrast. That's the ballooning of the outflow tract. This mild stenosis will fix the pre-stent coming now here. And finally, here we can see that the mild stenosis will fix it a little bit. And finally, the melody valve. That's the same patient, but during real catheterization, so the images are very comparable. That's another patient with a narrow outflow tract, but not an outflow tract, a stenosis here in just before the bifurcation. That's the real catheter, that's the model. That's the look from the B camera. The silicone reacts a little bit like normal tissue. And finally, the implantation of the melody valve. So to conclude, whenever we have available volumetric image information, we should use it and reconstruct them three-dimensionally to optimize the clinical course of our patients. Thank you.